In this last discussion, in order to close off the chapter, we're going to cover both cardiomyopathy and cardiac tumors. Cardiomyopathy refers to myocardial diseases that result in cardiac dysfunction. The first is called dilated cardiomyopathy. In this particular case, you get dilatation of all four chambers of the heart. This is the most common form of cardiomyopathy. Here's what it looks like. You get massively dilated chambers of the heart. You can look at the two atria here, and you can look at the two ventricles here. Now the problem with this is that it's going to result in a systolic dysfunction. If you stretch the heart so that it's no longer able to contract properly, that massive stretching of the heart is then going to result in a problem with systole so that you won't be able to empty the heart. And of course that's going to result in biventricular congestive heart failure. Both the left and the right sides are both going to fail together. The complications include mitral and tricuspid valve regurgitation. Imagine that if this is the heart here, and you've got the right atrium, right ventricle, left atrium, left ventricle. As you stretch this heart, you're going to be stretching the mitral valve and the tricuspid valve. Again, this is the tricuspid. And then you'll stretch the mitral valve. And again, that stretching is going to result in a regurgitation of those valves. So number one, you get systolic dysfunction, and number two, you're going to get stretching and regurgitation of these valves. Another complication would be arrhythmia. The way I think about this is that as you stretch the heart, you're also stretching the conduction systems of the heart, and so you're going to start getting funny conductions across that system, giving you arrhythmias. Now, most commonly, dilated cardiomyopathy is idiopathic. We don't know the cause, but some very high-yield causes to be aware of include genetic mutations. Usually the most common genetic mutation would be autosomal dominant. Myocarditis can do it. The most common bug to cause myocarditis would be Coxsackie virus. That results in a lymphocytic infiltrate in the myocardium. The patients get chest pain. They can get arrhythmia with sudden death. They can get heart failure. If they manage to survive the myocarditis, then one of the late complications is dilated cardiomyopathy. Alcohol abuse, very high yield, can cause a dilated cardiomyopathy. There are some drugs that can cause it. For example, doxorubicin can result in a dilated cardiomyopathy, and so can cocaine. And then finally, particularly high yield is pregnancy. Women who are pregnant either late in the third trimester or, for example, soon after birth can develop heart failure due to a dilated cardiomyopathy. Now here's a picture of myocarditis just to remind you of myocarditis as a cause of dilated cardiomyopathy. You can see all the lymphocytes present within the myocardium. Again, myocarditis, most common cause, Coxsackie virus. And this can result in death during the acute phase, or if the patient survived, can eventually result in dilated cardiomyopathy. Now, the treatment for dilated cardiomyopathy is transplant. There's no way to fix that dilated heart. Hypertrophic cardiomyopathy is when you get massive hypertrophy of the left ventricle. The most common cause, and of course very high yield, is that you get genetic mutations in the sarcomere proteins, high yield, most commonly autosomal dominant. Now, these patients are going to get decreased cardiac output. And the reason is because the hypertrophy makes the heart wall so tight that you can't fill the heart anymore. Basically, the wall becomes so full of muscle that you lose compliance. And so you get a diastolic dysfunction where you can't fill the heart. At the same time, the patients can get sudden death due to ventricular arrhythmias. This is the most common cause of sudden death in young athletes, and we're all aware of those athletes that are playing on the field and all of a sudden pass out. And that's classically due to a hypertrophic cardiomyopathy. Another complication is syncope with exercise. We can illustrate that very quickly. Right atrium, right ventricle, left atrium, left ventricle. And the idea here is that you get this preferential involvement of the intraventricular septum right beneath the aortic valve. Now this is basically going to create almost like a relative block, the same way that aortic stenosis would create a block. This would create a relative block so that you wouldn't be able to get blood across this very well. And that would then present with syncope during exercise. So that's basically you get a functional aortic stenosis. Now, if biopsy were performed, you would see myofiber hypertrophy with disarray. And this is a particularly high-yield image, so let me just take you through it. Normally, when you look at the myocytes, they should all sort of be lined up very nicely and in parallel. However, notice here that there's all this disorganization with the myocytes sort of going in every different direction. And that's called myocyte disarray. And it's the classic finding in hypertrophic cardiomyopathy. Restrictive cardiomyopathy is when you are restricted from filling the heart, and that's because there's a decreased compliance of the ventricular endomyocardium. Again, you can't fill, so there'll be a diastolic problem. Now, what are the causes? Amyloid can fill the heart, making the heart very difficult to expand, and so therefore that would result in a restrictive cardiomyopathy. Sarcoidosis, the granulomas of sarcoidosis can get into the wall of the heart, making it difficult to expand, resulting in a restrictive cardiomyopathy. Hemochromatosis, if iron gets into the wall of the heart, it can do the same thing. There's an interesting disorder called endocardial fibroelastosis, and this is when patients have a dense layer of fibrosis and elastic tissue in the endocardium. Now remember that the layers of the heart are the endocardium, and then the myocardium, and then the epicardium. Now imagine if this endocardium becomes massively fibrosed and thickened with elastic tissue, you won't be able to stretch this when you expand the heart open, and so that would then result in a restrictive cardiomyopathy. Now I should note that endocardial fibroelastosis would classically be seen in children, and so it's one of the rare causes of a restrictive cardiomyopathy in children. Another cause of restrictive cardiomyopathy is Loeffler syndrome. The idea here is that you get an eosinophilic infiltrate with inflammation within the wall of the heart, again with eosinophils, and that results in fibrosis of the endomyocardium, both the endocardium and the myocardium. Of course, this fibrosis would then make it difficult for the heart to expand and fill, and so you'd get a restrictive cardiomyopathy. Patients with a restrictive cardiomyopathy will present with congestive heart failure, and again, that's because they're not able to fill the heart, so the blood will back up behind the heart. And the classic finding on EKG, because you've got all this material on the wall of the heart, will be low voltage EKG with diminished QRS amplitudes, and that's important to note as well. The final section of this chapter deals with cardiac tumors. It's very straightforward. The first cardiac tumor is called a myxoma. This is a mesenchymal proliferation where you get a gelatinous appearance to the tumor. On histology, it shows abundant ground substance, and that's what makes it look so gelatinous. And this is the most common primary cardiac tumor in adults. Remember that in adults, the cardiac myocytes are permanent cells, and so therefore they're not going to be able to produce a tumor. So the only real tumor of the heart that you're going to get is going to be a tumor of the mesenchymal connective tissue. Again, that's called a myxoma. Now this tumor normally grows in the left atrium as a pedunculated mass, and it can cause syncope due to obstruction of the mitral valve. Let's briefly illustrate this. Here's a picture of the heart. Again, these are our four chambers, and in this particular case, we're in the left atrium, and you've got this pedunculated mass. Pedunculated means it grows off a little stalk. And so you've got this pedunculated mass. Now this mass could easily block the mitral valve here. And were it to block the mitral valve, that would block the blood flow through the heart. Of course, blood would not go to the brain then, and so you'd get syncope. And so that's why we say here in the book that it causes syncope due to obstruction of the mitral valve. The next tumor is rhabdomyoma. Rhabdomyo means striated muscle, and oma means mass. This is a benign hamartoma of cardiac muscle. It's the most common primary cardiac tumor in children. High yield, it's associated with tuberous sclerosis. That is very high yield, and it usually arises in the ventricle. Now, the last discussion about cardiac tumors involves metastases. Metastasis to the heart is more common than primary tumors. And common metastases to the heart, they include breast and lung cancer, melanoma, and lymphoma. These are the tumors that love to go to the heart. When they go to the heart, they usually go to the pericardium, and it results in a pericardial effusion. And so that closes off both the section and this chapter.